Hello, my name is DeAnna Baker Frost, and I'm an assistant professor at the Medical University of South Carolina. And today I'll be talking about scleroderma in African American patients. I would like to thank the organizers of this conference for giving me the opportunity to talk about this subject. I do not have any financial disclosures that are relevant to this talk. So our outline for our discussion today will include a discussion about the disease characteristics that are prominent in African American patients. We will also discuss current research topics which explore the causes of these differences and to pose any remaining questions that will help us to get at a better answer as to why these disparities take place. So as you well aware are, I'm sure you're well aware that there are different subtypes of scleroderma. There is the limited subtype and there is the diffuse subtype. The limited subtype, the skin thickening, which is one of the hallmarks of scleroderma, is confined to the fingers, the forearms, the face, the feet, and the legs, while the diffuse subtype, the skin thickening extends above the elbows, which involves the chest, the abdomen, and the thighs. In African American patients, they tend to have more of the diffuse form of the disease. They develop scleroderma at an earlier age, and they tend to have more severe disease when they do develop scleroderma. So I'll draw your attention to the graph on the right, which just depicts just that. The blue line represents African American females, while the green line represents Caucasian females, and the pink line represents African American males, and the orange line represents Caucasian males. And as you can see, comparing African American females to Caucasian females, there's an earlier onset of disease and a higher prevalence of the disease in African American females. And you see a similar trend with African American males compared to Caucasian males, in that there's an earlier onset of the disease and is a higher prevalence of the disease in African American males. As we look at the survival of African American patients that develop scleroderma, we see that African Americans unfortunately have a decreased survival. So if we look at this graph once again, the green line represents African Americans, and the green line represents non-African Americans, and the blue line represents African Americans. And on the left, 1 represents 100%, which means 100% survival. And the line at the bottom here represents the number of years after the initial visit. And as you can see, as we go out from the number of years, the number of patients that survive unfortunately decreases with time. However, with African Americans, there's a sharper decline in the number of patients that survive compared to non-African Americans. And this difference between these two lines are statistically significant. And as we look at some of the clinical characteristics that's quite prevalent in scleroderma, we can see some differences with African American patients and non-African American patients. So as I mentioned before, one of the hallmarks of the disease is skin tightening. So as we look at skin disease, skin thickness is what causes the skin tightening to occur. And our trained rheumatologist in scleroderma is well familiar with a scoring system that we always do in our patients to quantify the amount of skin thickness that takes place. So over here, we see 17 different areas of the body in which skin tightness is measured, including the face, the chest, the abdomen, and both arms, the forearms, the hands, the fingers, the thighs, the legs, and the feet. And as we assess these different areas, is given a score of 0, meaning pretty normal skin, a 1 or 2 or 3, which is highly involved skin thickening. And when we look at our African American patients that have diffuse scleroderma, they tend to have a higher skin score compared to patients that are non-African Americans and have diffuse disease. Another thing that takes place in our African American patients is that the color changes of their skin is more prominent than non-African American patients. So here are some depictions of an African American patient that's diagnosed with scleroderma. And as you can see, her chest is shiny, which represents skin thickening that's taking place in her chest. You can also see involvement in her face as well. But some of the other things that you can see is you can see some changes in the actual pigment of her skin. So I'll draw your attention to her hands. You can see some lighter areas here and some darker areas here. You can also see an interchange in lighter areas and darker areas in her arm. And if we take a closer look at that, we often say that these changes are salt and pepper changes, or poikiloderma is the other name for it. And so you can see areas that are interspersed with light areas as well as darkened areas here. Again, we see more areas of lighter areas around the fingertips, and we see some lighter areas on the back and the neck area of this patient. The hyper, or the darkened areas of the skin, typically happens after inflammation has resolved. So the hyperpigmented changes are typically the result of inflammation that is slowly resolving in scleroderma. There are several medications that we often use to treat skin disease. There are a list of oral medications including mycophenolate mofetil and methotrexate, some of which you might be familiar with. There are also infusion medications and injectable medications that we often use to help with the skin disease, including cyclophosphamide, which can also be given orally. Methotrexate can also be given as an injectable medication. Intravenous immunoglobulin, also known as IVIG, can be another option. These are the antibodies that are collected after patients give blood, and they're pooled together and infused in patients that have scleroderma. Tocilizumab is one of the newest medications that's recently been FDA approved to help with lung disease, which we'll talk about a little bit later, but it can also be helpful in some instances in skin disease. And it's also been shown that patients that undergo stem cell transplantation also has an improvement in their skin disease. Other things that are very important for our patients to consider if they do undergo these color changes of the skin is sun protection. That includes wearing clothing to protect you from the sun, and hats as well. Sunglasses are also very important, as well as sunscreen. And we recommend using sunscreen that will protect you against UVA as well as UVB radiation. And we would like you to use sunscreen that's an SPF of greater than 30. Vitamin A preparations can also be helpful to help with some of the color changes as well, to bring back kind of the natural skin color for our patients. And oftentimes, patients require medications that are not available over the counter and require prescriptions. And so therefore, referral to dermatologists that are familiar with scleroderma and are familiar with the color changes that take place in scleroderma patients can also be helpful. Another clinical characteristic that's often seen in patients with scleroderma is Raynaud's phenomenon. And again, I'm sure all of you are familiar with the color changes of the fingers that takes place with Raynaud's phenomenon in cold weather. It can also take place in other extremities, including the toes. However, because of the pigment of African American patients, sometimes Raynaud's phenomenon is a little bit less recognized in African American patients. And interestingly, African American patients are more likely to have digital pits related to Raynaud's phenomena, which are basically indentations in their digits as a result of the Raynaud's phenomenon. Some treatment options for this includes amlodipine, nifedipine, nitroglycerin ointment that's used in the web spaces of the fingers, as well as sildenafil, all of which are effective in causing opening of the blood vessel, also known as vasodilation. Another clinical characteristic that unfortunately affects our patients with scleroderma is gastrointestinal disease. So if we look at the depiction on the right, this is a simplistic view of the gastrointestinal tract, and it can be divided into the upper gastrointestinal tract and the lower gastrointestinal tract. So the upper gastrointestinal tract involves the mouth, the stomach, and the upper part of the small intestine, as well as the esophagus. The lower gastrointestinal tract involves the lower part of the small intestine, the large intestine, the colon, as well as the anus. Unfortunately, African American patients have more involvement of the small intestine when their scleroderma affects their gastrointestinal tract. And the manifestations of that includes, but not excluding, constipation, diarrhea, bloating, vomiting, and weight loss. There are several treatment options for gastrointestinal disease, including using proton pump inhibitors to help with acid reflux. Occasionally, patients may need esophageal dilatation, which means stretching of the esophagus when they have strictures that take place that makes it difficult to swallow foods as well as liquids. Antibiotics often can be used for the gastrointestinal disease as well. Because scleroderma affects the movement of the gastrointestinal tract, bacteria can sit in this area and are allowed to populate and overgrow. And so one treatment for this is going through different antibiotics, kind of through a cycle, to help to decrease the amount of bacteria that overgrows in the gastrointestinal tract. Interestingly, some antibiotics actually have motility effects, meaning that they promote the movement of the gastrointestinal tract. So some antibiotics can be used even for the motility effects of the medication. And laxatives often have to be used to help with the constipation. Another clinical characteristic that we're well familiar with is the lung disease that takes place. So the form of lung disease that happens in scleroderma is interstitial lung disease. This is caused by the inflammation that takes place from the immune system that leads to scarring, also known as fibrosis. The increased amount of fibrosis that develops in the lung over time prevents the lungs from adequately functioning and causes the shortness of breath that's often experienced. Unfortunately, interstitial lung disease is more common in African American patients. It's also more common in patients with diffuse scleroderma. When African American patients do develop interstitial lung disease, it is more severe. And the severity is measured by the abnormality of the breathing test or the pulmonary function test that we monitor on a regular basis in our patients. It can also be seen in lung imaging, including CAT scans that occur in our patients. Also, African American patients, due to the severity of their disease, are more likely to have to use oxygen. There are, again, several medications used to treat lung disease, and some of these medications may be familiar because some of them are the same medications that we use to also treat skin disease, including mycophenolate mofetil. Azathioprine has been used to treat lung disease, as well as cyclophosphamide. Again, as I mentioned before, tocilizumab is one of the newest medications that recently has been FDA approved for scleroderma-related lung disease. Cyclophosphamide is also used, as well as nintedanib, or also called OFEB, which is another recent FDA-approved medication. And again, stem cell transplant has been very effective for helping patients that have lung disease. Another clinical characteristic that can take place is pulmonary hypertension. So pulmonary hypertension is the increased resistance in the arteries of the heart. And because of this increased resistance, blood flow is compromised, which can lead to increased fatigue and shortness of breath, as well as swelling to occur in the extremities of our patients. African American patients are diagnosed with this complication at an earlier age, and they also tend to have more severe disease once they are diagnosed with pulmonary hypertension. Some treatments for pulmonary hypertension include sildenafil, bosentan, iloprost, treprostinil, and abrasentan. Renal crisis is one of the rheumatologic emergencies that we consider for our patients in scleroderma. So renal crisis is characterized by dangerously high blood pressure, kidney failure, and platelet counts, and which is why it's very important to monitor your blood pressure on a frequent basis if you have scleroderma. Unfortunately, renal crisis happens more frequently in African American patients. And one of the main treatments for this is a blood medication called angiotensin converting enzymes, or ACE inhibitors. And finally, there are several lab tests that we check in our scleroderma patients, but I'm going to highlight the ones that are found more frequently in African American scleroderma patients. So the anti-nuclear antibody is one of the tests that is seen positive in a number of scleroderma patients, including African Americans, but particularly the nucleolar pattern is seen more frequently in African American patients that have scleroderma. The ANA test actually looks at the nucleus of the cells, and when you look at the nucleus, you can actually see different patterns that light up, and one of those patterns is the nucleolar pattern. Anti-U1 RNP and anti-U3 RNP are also autoantibodies that can be positive in African American patients that have scleroderma. Those that are positive for the anti-U3 RNP are more likely to develop pulmonary hypertension. They're more likely to have muscle inflammation, which I'll talk about a little bit more in a second. And they also have more severe gastrointestinal involvement. They are also more likely to have a positive SSA and SSB autoantibody. And these antibodies are also seen in autoimmune disease entitled Sjogren's syndrome that causes significant dry eyes and dry mouth, amongst other complications. African American patients are also more likely to have a high level of creatinine phosphokinase, also known as CPK or CK. This is a measurement of your muscle enzymes. And if these are detected at high levels in the blood, that could mean that there is muscle inflammation that is taking place, or myositis. So that goes along with the anti-U3 RNP. And African American patients are more likely to have muscle involvement related to their scleroderma. Some of the symptoms associated with muscle involvement includes extreme weakness, especially in the hips and in the shoulders. So we've just outlined several different clinical characteristics that are different in African American patients that have scleroderma. And so now we want to discuss possibilities as to why these differences may take place in our scleroderma patients. One possibility is that when African American patients are diagnosed with scleroderma, they could be at a later time point in their disease, and so they present to their physicians with more severe symptoms, which is why these could be affecting their prognosis or their survival data. It's known that skin changes can take place before skin thickening can take place in African American scleroderma patients. And so because skin thickening is one of the hallmarks of scleroderma, if a clinician sees the color changes before the skin thickening, that could be a cause of a delay in diagnosis with scleroderma. Additionally, patients that have lung disease can experience a wide variety of symptoms, and sometimes those symptoms aren't necessarily thought of as related to lung disease. So shortness of breath with activity is a classic symptom that can be seen with lung disease. However, before a patient develops the shortness of breath with activity, they could have symptoms such as fatigue, dry cough, they could have chest pain, and they could have decreased exercise tolerance, meaning that they notice that they can't climb the number of stairs that they normally would climb, or they can't walk as far as they normally would walk, or they can't carry the number of bags that they normally would carry. And all of those things may not necessarily sound related to lung disease, but they can also be symptoms of lung disease as well. So when a patient presents to a clinician with some symptoms, such as the ones I have just named, it may not necessarily be connected to lung disease and therefore could delay the diagnosis of scleroderma. Another interesting thing is that patients that have one autoimmune are more likely to develop other autoimmune diseases, unfortunately. And so if a clinician is focused on just one autoimmune disease, they may miss that a patient may have other autoimmune diseases in addition to that one, including scleroderma. So for instance, we talked about African American patients having high levels of CK or CPK, the muscle enzyme. And so African American patients are more likely to have myositis in addition to their scleroderma. Or they may also have rheumatoid arthritis in addition to their scleroderma, which manifests more as joint pain. African American patients are also more likely to have lupus in addition to their scleroderma. So the presence of having these other autoimmune diseases may draw the attention away from the diagnosis of scleroderma, which would again delay the diagnosis of scleroderma, causing the disease to continue without treatment. We mentioned before that African American patients can also have a positive ANA test as well. It's been circulated throughout medicine, and some clinicians associate a positive ANA test with only lupus and not other autoimmune diseases. So if a scleroderma patient presents with just a positive ANA test, they may get misdiagnosed with lupus because they could have the positive ANA test and joint pains and not readily associate that with scleroderma. So if they're misdiagnosed with lupus, then they're typically started on medications for lupus, which is not helpful for scleroderma, which then would also delay starting effective treatment to treat their scleroderma disease. In addition to a delay in diagnosis, there could possibly be genetic differences in African American patients compared to non-African American patients that could explain the differences in presentation as well as severity and survival. So there is a group of researchers involved in a study called the Genome Research in African American Scleroderma Patients, or the GRASP study. This is an NIH study. NIH stands for the National Institutes of Health, and they are studying genetic associations in African American patients. So all of these clinicians, scientists see scleroderma patients at their respective institutions, and they consent these patients to collect blood and to perform genetic studies with their consent to look at differences in genes among African Americans and non-African American patients to look for similarities as well as differences. And through this study thus far, they have recognized new genes that were not necessarily associated with scleroderma, or different genes between African American and non-African American patients with scleroderma that may be important in the long term to explain these differences. In addition to looking at the genetic makeup of the blood between African American and non-African American scleroderma patients, researchers are also looking at specific organs that are affected by scleroderma to look at the cells to see if they can see differences there that can explain these differences. So, for instance, skin cells have been isolated from African American and non-African American patients with scleroderma to compare and contrast differences. And there have been differences that have been noted in the modifications of the DNA between African American and non-African American patients. And that's important because these modifications of the DNA can have effects on the types of genes that are transcribed or genes that are turned on, and proteins that are made that could have effects on how a patient responds to medication or how long they survive with the disease. The immune cells are also very, very important in scleroderma because these are the cells that are important for starting the inflammation that takes place in scleroderma. And so the immune cells have also been isolated from African American and non-African American patients. And it's been shown that there are certain proteins that are different that are turned on and turned off in African American and non-African American patients. They've also found some changes in the type of DNA that's turned on and off in these immune cells as well. And then finally, the lung cells and the fluid that can be present in the lungs sometimes have also been looked at to consider differences between African American and non-African American patients. And with examination of these lung cells, they have found differences in the proteins that activate the immune system as well as decrease fibrosis. So all of these research studies are going on at the same time. It may not seem that they're related, but all of them work together to give us a better picture of what's happening inside of a patient that's African American versus not, to help explain these differences. Another interesting aspect is how patients respond to medications, and if there are certain medications that may be more effective in African American patients versus non-African American patients. This has been demonstrated in lupus. So African American patients do respond better to a certain treatment for kidney disease and lupus than non-African American patients, and that has shaped how lupus patients are treated. And so interestingly, a recent study has been done on a clinical trial that took place several years ago called the Scleroderma Lung Study 2. And when they looked at their African American patients, they did see that African American patients that were treated with cyclophosphamide did show an improvement in their lung function test compared to non-African American patients. And also African American patients in a whole had a trend for better survival compared to non-African American patients. So this is the graph of what I just described in words. So in the upper left corner here, the dotted line represents African American patients. The solid line represents non-African American patients. And over here on the left is one of the parameters we use to measure lung function. And at the bottom is the number of months that the patients were treated with cyclophosphamide. CYC stands for cyclophosphamide. And as you can see here, the African American patients actually had a greater improvement in their lung function test tests early on when they were treated with cyclophosphamide compared to non-African American patients, and the difference there was noted to be statistically significant. And if we look in the lower right corner here, again, with one being 100% survival and the dotted line being African American, that there is a greater survival over the number of years with African American patients compared to non-African American patients. However, that difference was not statistically significant. And so we have outlined that there definitely could be biological reasons that African American patients have more severe disease and have differences in their presentation for scleroderma based on genetic studies and even their response to medications. However, there could be other factors that may be non-biologic that plays a role into these differences as well. And so we always have to remember that race is a social construct. And at its foundation, it's not was based on biologic differences. Based on the definition of race that was offered by Dr. Witzig, race is therefore an unscientific social construct. And so based on that, we always have to think about non-biologic factors that could explain some of the differences between our African American patients. So one of those things could be socioeconomic status. And so the differences that we noted in our patients are by and large related on separate cohorts of patients throughout the country and in individual academic medical centers. So there's lots of studies, as we've talked about this entire talk, to show that survival rates are lower in African American patients. However, there are some studies where there was not a difference in the death rates of African American and non-African American scleroderma patients. And there was one study to show that there are other factors that may explain some of the differences, including socioeconomic. So income differences was found to be a very important factor, even more important than race in a particular cohort of patients. And that income difference did affect patient survival. So some of the remaining questions that we still have to help us, again, understand these disparities is, would exposure to the variety of scleroderma symptoms shorten the time to diagnosis and improve disease outcomes? Are there other unknown biological factors that cause worse disease in African American patients? Are there treatments that are more effective in African American patients versus non-African American patients? And would disease outcomes improve with equitable social and economic status as well as access to care? So in summary, scleroderma has several different disease characteristics that can be different and or more severe in African American patients. Medications have been effective, but we always need more targeted treatment options. And more research is needed to understand what leads to the differences in African American patient outcomes. Thank you very much for listening to my talk, and I'll be happy to take any additional questions that are available.